Thank you so much. A very good morning, happy Sunday, and thanks to all the organizers for having given me this opportunity. And thanks for the warm introduction, Abhilash sir. As sir said, I have been given a very important task of talking about the role of anti-diabetic agents in ASCVD. My previous speakers have spoken so eloquently and beautifully about the cardiac part as well as the role of SGLT2, and therefore I need not go more into the introduction and can dive straight in. As you know, I have been given only 13 minutes to discuss this, so I have to be quite brief with it. And what I think is this talk can change the way we practice diabetes. The series of talks that we are having right now have this effect on your daily practice as well. Now, coming to a brief introduction about atherosclerotic cardiovascular disease and anti-diabetes agents. We all know that the definition of ASCVD, as already spoken by the cardiologist here, and that diabetes increases the risk, and diabetes itself is a risk for ASCVD. Now, having said that, whenever we talk about ASCVD and when we talk about high-risk ASCVD, we need to know how do we define a patient as high-risk. And for that, the best tool would be a ASCVD assessments tool, which has been made by the American College of Cardiology and the American Heart Association. We can get it from the link, and then we can be able to look into what is the risk for that particular patient. So estimating a patient's 10-year risk of developing an ASCVD will help to categorize the patient. So this is the risk estimator. When we look into the age, gender, race, blood pressure, cholesterol levels, diabetes, and as well as hypertension, cholesterol tablets, as well as aspirin. So depending on all these, we put the patient into a risk category, and that is done automatically by the calculator. And then we come up with the low risk, borderline risk, intermediate risk, and high risk. So that's what we define by high risk ASCVD. So I think we should be able to use this calculator in our daily practice, and that is the first thing that I would tell people, because only then we can get into the algorithm properly. Now, having said that, the agenda for today will be more on the recent last 12 years of CVOT type 2 diabetes, where it all started. A quick peek into CVOTs in diabetes, because we have 26 CVOTs and I have 30 minutes time. And we are into the cardiovascular safety of the modern sulfonylureas in CVOT. What are the implications for these for clinical practice for diabetes, and how CVOTs have helped to design our approach to diabetes? So that's the agenda for today. Now let us come to the CVOT era, or what is CVOT as such, and how it all started. It was already said by the previous speaker, but let me put a small quiz here. Those who are interested in quizzes early in the morning on a Sunday, this one is for you. I have 4 questions. The first one is this: in which year did the FDA introduce CVOT trials for diabetes? Okay, I'll give you 3 seconds to answer that. You can put it in a comment box, and then we'll go to the answer. This is just to know, make things more better. Yeah. So as you know, as was already spoken with the first speaker, it was in 2008 when the FDA came up with this. The same similar slide was also put by the speaker, but when they said that from here onwards, trials on diabetes agents should have a CVOT or an outcome trial. Now coming to the quiz number 2, what was the drug, and after reviewing which trial did the FDA come up with the CVOT? Of course, a lot of you will be knowing about the drug, but what was the trial that they looked into? So again, 3 seconds for that. You can go into the comment box about the drug. That's the easy part, and about the drug. Yeah. So as you know, it was the rosiglitazone fiasco, which was already said by the first speaker. Rosiglitazone was the drug, and the trial was the ADOPT, or the diabetes outcome prevention trial, or ADOPT, in which they found that the percentage decrease, although there was a decrease in HbA1c, they found that the risk of congestive heart failure and cardiovascular ischemia were higher, and therefore a paradigm shift was made by the FDA that here onwards for drug clinical trials, the endpoint should be clinical endpoints and not a surrogate biochemical endpoints. Now this comes to quiz number 3. Which was the other drug apart from rosiglitazone that influenced FDA to enforce a CVOT? I mean to say that what was the drug previous to this drug, which again made people think about why don't we change the way we do trials. So another 3 seconds to you. Yeah. So the other drug was in 2005-06. It was muraglitazar, and they looked at this was again a PPAR agonist, which had action both on the alpha and the gamma receptors. And again, muraglitazar had its own problems, and there was a huge uproar on what was the standards by which the FDA used consent to trials, and when the final nail in the coffin was by rosiglitazone. And this is post CVOT. So, which was the first anti-diabetes agent to undergo CVOT trial? A cardiovascular outcome trial, which was the first anti-diabetes agent. 3 seconds to you on the comment box. 1, 2, and 3. So, bromocriptine. Bromocriptine was the first drug to undergo CVOT. I could see Abhilash sir's eyes brightening up. So let me go into the next one. So what's the difference between a normal conventional glycemic efficacy trial and what is a CVOT, which is a cardiovascular outcome trial? Well, the difference is that the CVOT is more an expansive one. It's like a gold standard. It's quite difficult, and it involves a lot of financial support as well as logistical support, because you're going to compare CV outcomes. You're going to use people who have risk factors, and you're going to see patients in thousands. The duration is going to be for many years or up to a particular event, and the investigator, it's going to be multi-centric investigators, and usually the comparator will be a placebo. And the most important thing is the inclusion criteria, that patients with high CV risk factors, known atherosclerotic vascular disease, and a recent CV events will also be included in this. So that's the basic difference between a conventional and a CVOT. Now, having said that, in 2018, the AACE came up with an article on cardiovascular outcome trials and type 2 diabetes. I'm going to touch upon these things and then quickly go into the other aspects of it. As I said, in a CVOT trial, what we're basically looking into is either a non-inferiority and, if possible, a superiority as well. So agents shown to have cardiovascular safety, till now, almost all antihyperglycemic agents evaluated in CVOT today have shown to be CV safe. And agents shown to reduce CV outcomes have been SGLT2 inhibitors and also liraglutide and semaglutide. Now, for this, what I've looked into as a composite of the major adverse CV events, or the MACE, are: one is the CV death, non-fatal MI, and non-fatal stroke. So these are the composite endpoints which they looked into for most of these CVOTs. As I said, there are about 26 CVOTs till now, and with 13 minutes time, I don't have much to touch upon everything, but I'm going into the classes of drugs and the most important trials which have been done, and what is the implication in our practice as such. So let us go into GLP. SGLT2 has already been discussed. We'll go into GLP1 and then come into SGLT2 and DPP4. Now, as far as the GLP1 receptors are concerned, we know what they are, what they do, what are the FDA approved agents: albiglutide, dulaglutide, exenatide, extended release liraglutide, semaglutide, and lixisenatide. Now, having said that, GLP1 receptor agonist trial is the most famous one, is the leader trial. And the leader trial, what it showed us is that in time to event analysis, the rate of first occurrence of death from CV causes non-fatal MI or non-fatal stroke among patients was lower with liraglutide than with placebo. You can see the reduction rate of 13% events and 22% for CV death. So the consensus was more in favor of liraglutide, and thereby it gave an opportunity for the FDA for a new approval for liraglutide based on the leader trial, where they have given an approval for 1.2 and 1.8 to reduce the risk of major adverse cardiovascular events, MACE, in adults with type 2 diabetes and an established cardiovascular disease. The other molecules, of course, there have been a lot of other molecules which we looked into. One is the Sustain 6 for semaglutide, Elixa for lixisenatide, Excel, and Rewind. So these are other trials, but I'm just touching upon the major trials which have made an impact in our daily practice. Coming to SGLT2, as has been already eloquently described by the previous speaker from Calcutta, we know what SGLT2 are and the approved agents as such. And sir already discussed about the EMPA-REX study. Even Dr. Uni had already discussed about it, so I will not go much into the EMPA-REX study. But what I would like to say is that patients with type 2 diabetes at high risk for cardiovascular events who received EMPA versus placebo added to standard care had a lower rate of primary composite CV outcomes, and the percentage was staggering, and of death from any other cause. Again, this made the FDA, apart from not only the cardiac part, but also the renal part, SGLT2 inhibitors in the EMPA-REX renal arm, they showed that the renal outcomes with empagliflozin over 3.2 years showed a reduction rate of more than, say, 38%, 44%. And therefore, it helped FDA to come up with a newer approval for EPA to reduce cardiovascular deaths in adults type 2 diabetes in 2016. So these are some drum trials which have actually changed the way that we looked into the anti-diabetic agents, not only as an anti-hyperglycemic, but also in other aspects of CV reduction as well. Again, the most important Canva trial and how Canva has helped to again change the entire landscape of how we do things. There were two studies. One was the Canvas and the Canvas R. With I'm not going deeper into what the study was, what was the eligibility criteria, but again, FDA was able to approve canagliflozin to reduce cardiovascular deaths in adults with type 2 diabetes based on the staggering data which they had. But however, having said that, in 2017, the FDA again issued a black box warning on canagliflozin for amputation risk. And therefore, this was a big, an unexpected thing that happened because of after it came into the market. But very recently, as recent as last month, the FDA again withdrew the black box warning, and they said that collectively newly identified effects of canagliflozin on heart and kidney showed a significant enhanced benefit of this. Although the risk still exists, but it is not as much high as what was expected previously. So it is there still in the warnings and precautions, but the black box warning is being removed. So that's about Cana. There was another warning from FDA on SGLT2 inhibitors for diabetes, and that was on necrotizing fasciitis of the perineum, also known as the Fournier's gangrene. And this was in 2018. After the trials, we showed that consistently that after the drug came into the market, there have been some incidences of Fournier's gangrene as well. Of course, there have been other trials on SGLT2, like the Vertis CV and so on and so forth. But we'll come to an amalgamation of all that at the end of the talk. The third most important anti-diabetes agent that we look into is DPP-4 inhibitors. Again, TCOS has been the most talked about one. And they've also shown that in TCOS, sitagliptin results have been good, that adding sitagliptin to a usual care did not increase the risk of major CV events, hospitalization or heart failure. But concern was raised about adverse pancreatic effects. And it was not as good as SGLT2 inhibitors. And although results were not statistically significant, there was a risk about pancreatic effects as well. The other molecules which come into this picture are alogliptin and saxagliptin, and their trials of Examine and Saver-TIMI 53 respectively. Now, again, FDA, depending on these trials, came up with warnings about heart failure risk to type 2 diabetes medicines containing Saxa, Alo, and Sita. And the analysis was from the Saver-TIMI 53 and Examine, which found that 3.5% of patients hospitalized for heart failure versus 2.8% for placebo in the Saver, and 3.9% on Alo versus 3.3% for patients from the placebo. This is the gist of all the CVOTs which have been done for anti-diabetes agents. It also includes insulin at the bottom. So we are able to see that the advent of CVOT trials has changed the landscape of how we treat diabetes as such, because these trials have brought in bigger changes within the last 1 decade than what was there in the last 2 to 3 decades as such. Now, having said that, what is it that we can derive from these CVOT trials is that some agents significantly decrease the major adverse cardiac events in CVOTs, and they have been identified as empagliflozin, canagliflozin, semaglutide to some extent, and liraglutide. And the secondary endpoint of the all-cause death was also reduced by empagliflozin and liraglutide. Hospitalization for heart failure, again, SGLT2, empagliflozin, as already discussed by Sir. And heart failure risk may be increased sometimes with Alo and Saxa. As far as basal insulin, the preferred insulin initial formulation in patients has a neutral effect on cardiovascular outcomes as well as on cancer, because they've looked into GLARG. Now, having said that, what are the clinical implications that we're trying to say? As I said previously, it was only about glycemic control, but now we're also looking into CV safety as such. And the major learning from this CVOT is that based on the new evidence that specific SGLT2 inhibitors and specific GLP-1 receptor agonists, they improve cardiovascular outcomes as well as the secondary outcomes such as heart failure and renal disease progression in patients with an established CVD or a CKD. So that has been the most important learning from the sessions. And treatment decisions right now should not be solely based only on A1C or blood glucose level. They should also take into account the patient's individual CV risk profile. So that's how personalized now the diabetic treatment has started to be. And for this, I think we can use, as I said, the ASCVD risk calculator would be very useful in our day-to-day practice. Now, wait a minute. Have I spoken about all the anti-diabetes agents? We spoke about SGLT2 inhibitors, we spoke about GLP-1, DPP-4, but are we missing something? What about the safety of sulfonylureas? Are the modern sulfonylureas dangerous, or are they wrongly accused? There was again an expert opinion by international panel, which was headed by Dr. Sanjay Kalra sir, where they looked into the utility of modern sulfonylureas from the cardiovascular outcome trials and the landmark trials. And they looked into the sulfonylurea arm, which has been used in the different CVOTs. And the panel recommendation has been encouraging that second and third generation sulfonylureas are not associated with an increased risk of all-cause mortality, CV mortality, MI or stroke. And guidelines consider modern sulfonylureas to be cardio-safe. And therefore, the panel opined that modern sulfonylureas are cardio-safe and preferable over the conventional in patients with diabetes and CV disease. And after coming over this with 12 years of CVOT, just when we thought we've learned a lot and that's going to be exciting, this came in March 2020, where the FDA withdrew the clause saying that in further from now onwards, diabetes drug approvals do not require CVOT. And that is a different topic altogether because of the cost involved, as well as we have not found drugs which are, because of this, we have not found drugs which are CV unsafe. So they said it can be done on a as required basis, and therefore they are withdrawing CVOT for all drug approvals. But having learned the lessons from the last 12 years, what is it that we have, how is it that our approach to diabetes has changed? Is that a person with diabetes and an established clinical ASCVD as per the calculator, we now do things like guideline directed medical therapy. As we know, lifestyle, antiplatelets, blood pressure, glucose lowering, the first is again metformin till now. And then except is going to be heart failure. And then about this new knowledge that we have developed about addition of an SGLT2 inhibitor or a GLP-1 receptor agonist. And then depending upon these two, which one to decide, again, it depends upon the clinician-patient discussion. So this is again the same thing, that if a patient is more than 18 years, has type 2 diabetes, we first look into an established clinical ASCVD is present or not. If it is present, then we consider whether it's going to be SGLT2 or it's going to be a GLP-1 receptor agonist. This has been beautifully summarized in the recent ADA guidelines, where they said the first thing is see whether the patient has ASCVD or a CKD. You can use the calculators for that. If ASCVD predominates, we go into whether from the newer CVOT experience, whether we can go for GLP-1 receptor agonists or SGLT2 inhibitors, and whether the HbA1c target is met or not. If it's going to be CKD, again we look into SGLT2 inhibitors. But if that is not the case, if ASCVD or CKD is not the case, then we look into whether we are looking at minimizing hypoglycemia, or are we looking into weight gain, weight loss, or is cost a major issue. So this type of personalization of diabetes has been possible just because we were able to do these CVOTs. I thank all for this wonderful opportunity. Thank you.